Excruciating pain.
A headache so severe it was described by female patients as worse than childbirth.
Unilateral orbitofrontal involvement with autonomic symptoms.
Cyclical and clockwork like recurrence?
What is this condition? Good
Good
day,
day,
everyone,
everyone. I am Najela.
and I am Kerwin. Today, we're going to talk about cluster headache.
Let's first open this discussion with a case from the UK. A 41-year-old man was seen at the headache clinic complaining of pain attacks which had woken him at 2 a.m. for the past 15 nights. The patient reported that he had suffered from a similar episode approximately 2 years previously. At that time, the attacks had also been very severe, although not as excruciating as his current attacks. The episode had lasted approximately 10 or 12 days, but he did not seek consult.
His descriptions localized the attacks to the right orbit and were of such extreme severity that the patient stated it was as if someone had pushed his eyeball out from behind or someone had stabbed a hot dagger through his eye. He also felt compelled to leave his bed and pace in his room. The attacks occurred regularly at 2 a.m., lasting between 30 to 60 minutes. He spoke of suicidal ideation during these attacks. He also reported reddening and tearing in his right eye as well as runniness in the right nostril. Afterward, he still experienced a dull pain on the right side of his head, but he was able to resume sleeping. Other than feeling fatigue, he had no other symptoms on the following mornings.
His use of over-the-counter analgesics included ibuprofen and paracetamol, but neither relieved the pain. Because the durations of the attacks were limited to approximately 1 hour, he wondered if the analgesics might have some effect. There was no family history of migraine or other headache disorders. As an accountant, he had a sedentary occupation but exercised in his free time and felt reasonably fit. He was a cigarette smoker and drank moderate amounts of wine and beer. What pathological condition could explain the patient's manifestations?
The patient most likely has a primary headache classified under the trigeminal autonomic cephalalgias or TACs. They are characterized by relatively short-lasting attacks of unilateral head pain associated with ipsilateral cranial autonomic symptoms such as lacrimation, conjunctival injection, oral fullness, or nasal congestion. Pain is usually severe and may occur more than once.
The main difference between these disease entities are the duration and frequency of attacks. Trigeminal autonomic cephalalgias include cluster headache, paroxysmal hemicrania, and short-lasting unilateral neuralgiform headache with conjunctival injection and tearing or your sunk, and your short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms or SUNA.
The key manifestations that may point to this diagnosis includes an attack and subsequent arousal during sleep, the need to get up and pace during an attack, and exacerbation by smoking and alcohol. Headache attacks lasting between 30 and 60 minutes may pertain to both cluster headache and paroxysmal hemicrania. This does not fit SOAP or SUNA, which usually has a shorter duration of seconds to minutes.
The rest of the clinical manifestations, including a prior cluster of episodes in the past, nocturnal occurrence, and responsiveness to oxygen therapy, sumatriptan, and prednisolone, all point to the diagnosis of cluster headache. The criteria for cluster headache, according to the International Headache Society, includes the following: at least 5 attacks of severe or very severe unilateral orbital, supraorbital, and or temporal pain lasting 15 to 180 minutes when untreated. Either or both of ipsilateral autonomic symptoms and a sense of restlessness or agitation during an attack. A frequency between every other day and 8 per day, and exclusion of other disorders.
Cluster headache was formerly known as Horton headache following the observations of Bayard T. Horton, a neurologist in North America. As mentioned, it is currently classified among TACs. The term cluster headache is derived from the periodicity of the attacks, which occur in clusters and then remit for various time spans. Cluster headache is a rare cause of headaches, which has an estimated prevalence of 0.1% in the general population. Men are affected more than women in a ratio of approximately 5:1.
The main age of initial presentation is 30 years, with an age range of 20 to 50 years old. However, onset in childhood has been reported. There is a familial component, but specific genes have not been identified. Lifestyle plays an important role. Patients with cluster headache are typically smokers and have frequent alcohol intake.
The pain in cluster headache is described as severe, non-throbbing, and explosive in quality. It has a unilateral involvement of the orbital or temporal area which may radiate into the forehead or the cheeks, less often to the ear, occiput, and neck. Maximum pain intensity is felt within 10 minutes of onset, and it may leave rapidly or fade away gradually. The attacks in cluster headache have a characteristic periodicity in its temporal pattern. It is described as a nightly recurrence between 1 to 2 hours after the onset of sleep or several times during the night for several or more consecutive days. This is the reason why it is also often called the alarm clock headache.
The autonomic signs and symptoms include nasal congestion, rhinorrhea, forehead and facial sweating, injected conjunctivum, lacrimation, miosis, flush and edema of the cheek, or slight ptosis. Ptosis may become permanent after repeated attacks. All of these manifest ipsilaterally as the orbital pain. Homolateral temporal artery may become prominent and tender, and skin over the scalp and face may become hyperalgesic.
Cluster headache is in turn divided into two types. Episodic cluster headache pertains to attacks fulfilling the criteria for cluster headache and occurring in cluster bout periods. There should be at least two cluster bout periods, each lasting from 7 days to 1 year when untreated, separated by pain-free remission of at least 3 months. On the other hand, chronic cluster headache pertains to attacks fulfilling criteria for cluster headache, occurring for at least 1 year without a remission period, or with remissions lasting less than 3 months. According to IHS, during the cluster period of episodic CH and at any time in chronic CH, attacks occur regularly and may be provoked by alcohol, histamine, or nitroglycerine.
The cause and mechanism of the syndrome remains incompletely understood. However, two leading hypotheses have shed a light to the possible pathophysiology behind the condition. In 1970, Ekblom and Graves observed in an arteriogram that there was a narrowing of the internal carotid artery during an attack. This was interpreted as being caused by the swelling of the arterial wall, which compromised the pericarotid sympathetic plexus and caused the Horner syndrome-like autonomic symptoms. The sympathetic deficit is peripheral, likely to be due to a parasympathetic activation with injury to the ascending sympathetic fibers surrounding a dilated carotid artery as it passes through the cranial cavity. This remains to be confirmed.
The second hypothesis points to a possible hypothalamic dysfunction. The attacks may be due to a hypothalamic mechanism that governs the circadian rhythm, which may explain its cyclical nature. During the onset of headaches, the region of the suprachiasmatic nucleus appears to be active on PET. It is likely to be a disorder involving the central pacemaker neurons and neurons in the posterior hypothalamic region. Autonomic symptoms are regarded as a consequence of hypothalamic disturbance with trigeminal discharge.
The treatment of cluster headache is based on empirical data and only a few clinical trials.
Treatment for acute attacks include the following. About 60% of patients with acute cluster headache respond well to oxygen inhalation, documented to stop attacks within 15 minutes. This should be given as 100% oxygen at 10 to 12 liters per minute for 15 to 20 minutes. It appears that high flow and high oxygen content are important. There are no side effects, but access to oxygen supply is a limitation.
Sumatriptan, a selective serotonin receptor agonist, can be administered subcutaneously with a dose of 6 milligrams. It has a rapid onset, often providing a painless state within 20 minutes in 70% of cases. It can shorten an attack to 10 to 15 minutes. Intranasal sumatriptan 20 mg and zolmitriptan 5 mg may be useful for patients who do not wish to self-inject daily. This therapy is contraindicated for patients with cardiovascular and cerebrovascular disorders and for those with untreated arterial hypertension.
Another possible therapy includes non-invasive vagus nerve stimulation or NVNS. The vagus nerve is a mixed motor and sensory nerve with projections to brain areas involved in pain modulation. Accordingly, non-invasive vagus nerve stimulation has been suggested to inhibit nociceptive processing. It uses 3 2-minute stimulation cycles applied consecutively at the onset of headache on the site of pain and may be repeated after 9 minutes. The usual nocturnal attacks of cluster headache can be treated with a single anticipatory dose of ergotamine at bedtime 2 mg orally. This drug is an ergot alkaloid. It is usually used for people older than 50 years old and is probably effective within 15 minutes. However, severe adverse effects such as vasoconstriction, soft tissue necrosis, distal paresthesia, and ulcers may be observed.
The choice of a preventive treatment in cluster headache depends in part on the length of the bout. For patients with relatively short bouts, limited courses of oral glucocorticoids can be very useful. 10-day course of prednisone or dexamethasone, beginning at 1 mg per kilogram daily for 7 days and followed by a rapid taper, may interrupt the pain bout for many patients. Most experts favor verapamil as the first-line preventive treatment for patients with chronic cluster headache or with prolonged bouts. The initial dose range is 40 to 80 mg twice daily. Effective doses may be as high as 960 mg per day. The main concern, however, is the cardiovascular safety of verapamil, particularly at high doses as it causes heart blocks. A baseline ECG is recommended for all patients.
Substantial progress has been achieved in the management of cluster headache using invasive and non-invasive neuromodulation techniques such as phenylpalatine ganglion stimulation, invasive occipital nerve stimulation, deep brain stimulation, and suboccipital injection of steroid. This ends our discussion on cluster headache. Once again, I am Kerwin.
And I am Najella from Group 5.
Thank you, and we hope that you learned something.